Okay, thank you. So the next speaker is Enrique Osorio, and the theme of the lecture will be the endoscopic lumbar disc herniation. Please.
Okay, thank you. Thank you very much. I will talk about the endoscopic lumbar discectomy. Okay, this is our team with Dr. Jorge Ramirez and Jose Rugeles, and I will show you our experience with the endoscopic discectomy. The indications, as you say, there are many, but for this case, the extrusion and these herniations. And we have these approaches. Posterolateral, we can do uni or biportal, and extremolateral and interlaminar approaches. For posterolateral, this is the position of the patient. All the patients we are doing under local anesthesia, and we enter between 8 to 12 centimeters and go directly to the disc. We introduce indigo carmine to differentiate very well the disc to the other structures, is to help in the surgery. When the patient have some other problem, some other in the disc, and we are not sure which one is the cause of the pain, we perform a discography and discogenic test. And also we have to in mind the Cambin security triangle, that in the top we have the dura mater, in the top we have the root, and in the inferior part we have in the center we have the disc. And we use laser, or in this case we use laser for many years to do the annulotomy and to do the mechanical discectomy. We use the great many instruments, and we can do with laser bone ablation. We can use the hook, we can use the spurs, and we can use many instruments to open the foramen to take out the disc. And in the last, really in the last 7 years, we use more the radio frequency, that with the same, we can coagulate, and we can also use all the instruments, the graspers, we can use the hooks, we can use all the instruments, and also to open the foramen with drills and everything. This is the technique that we use in these cases. And this is an example of this herniation, this posterolateral disc in the pre-op and in the post-op. And this case is very interesting. This is a white fighter, and he has 33 years at that time, with 5 months of very important lumbar pain. And this is the MRI with this disc in L4, L5, and in L5S1. In this case, we perform a discography and discogenic test that was negative in L5S1, And for that reason, we perform the endoscopy discectomy in L4 L5 and facet rhizolysis in L4 L5 L5 S1. And this is after surgery the same day. This is in December 2015, and 8 months later he got the gold the gold medal in the Olympic Games in Rio de Janeiro. 8 months later. In our experience in near to 3,000 patients between 1996 to 2020, under local anesthesia, outpatient procedure, we follow up with McNabb, BAS, and Old Westry tables, and with average follow-up of 10 years of the patients. Our results are with the modified McNabb criteria, 72% of the patients with excellent and good results, 14 of them with regular results, and 14 with bad results. And for the Oswestry, we had excellent and good results in 48% the patients, improved in 40% of the patients, but in 8% of the patients, worse in 4% of the patients, and open surgery we have to do in 5% of these patients. For the BAS in the pre-op was 8 per 10, and in the post-op 2 to 10. And the complications were 2.44% of the patients with the radiculitis in the 24, chemical dysitis 16, transitory motor disability in 18, and bacterial discitis in 6 patients. And for posterolateral and migrate hernias in L5 S1, we use interlaminar approach. This interlaminar approach we use because the interlaminar is very, very big, the window, and it is very easy to enter with the endoscope. Also used in L4, L5 disc herniations. And we enter is like a micro discectomy, but of course is with a very small incision. Enter 1 centimeter from the middle line, and we go directly to dissect the yellow ligament, and then to do the discectomy as usual, very small, very slow, and go out with the disc hernia, and until that we have to completely liberate the root, and that's it. You can see this case in the pre-op with this herniation posterolateral, and this is the post-op of the case, the pre and post-op. And here you have another examples of these herniations, this extrude herniation in the pre-op and in the post-op. The results in 185 patients is in the Oswestry score, excellent and good, 80% of the patients, improved 14 of the patients, but in 6% of the patients, and we had to do microdiscectomy in 6% of these patients. In the BAS, the pre-op 8 to 10 and post-op 3 to 10. And the complication, transitory hypoesthesia in 17 of the patients, transitory radiculitis in 14 of the patients, not infection, no CSF fistula. And for the extremolateral hernias, we use the technique of Choi, that is a straforaminal target fragmentectomy. We go directly to the fragment of the disc. And for that reason, we enter 5 to 8 centimeters of the medial line and go directly to the fragment. In this case, we can see this.
In patients with an extraforaminal extruded disc herniation, an extraforaminal approach can be made. In this case, the incision will be made approximately 4 to 6 centimeters from the midline, introducing the spinal needle with more than 45 degrees of angulation. In this third case, an extraforaminal approach was used to treat an extraforaminal herniation. The fragment retrieved was big enough not to be able to pass through the 4.1 millimeter working channel, so the endoscope was withdrawn with the fragment.
Okay, the results for extraforaminal approach is excellent in 41 of these patients. We had 51 patients between 2009 2020, and good results in 9 of the patients, but in one patient, no complications. And this is a very good approach because we have not to deal with the ganglion and the pain after the neuropathic pain after when you have to move the ganglion is very bad for the patient and very difficult to treat. We publish our results in some in many places, and as you see here, but we have now endoscopes with a working channel from 375 millimeter until now we have one of the working channel of 7.1 millimeter. That is very good because you have the possibility to introduce all the instruments that you need to do a very good microdiscectomy and also another procedures. And you see the comparative studies between microdiscectomy and endoscopic surgery. Here in 2014, this study, 8 studies compared endoscopic with microdiscectomy. There were no difference in surgical results. The endoscopic was associated with a lower risk of infection, but a higher reoperation rate. Microdiscectomy had a worse result in the criterion health-related quality of life. The conclusion was that the endoscopic discectomy has a potential advantage with respect to a lower risk of wound and urinary tract infections and a shorter hospital stay. And this meta-analysis of endoscopic discectomy versus open discectomy in these 9 studies, they found a significant difference in patient satisfaction, being 93 to better percent of endoscopic discectomy compared with 86% for microdiscectomy. There were no significant differences in rate of complications or in reoperations, although they were higher with microdiscectomy. Length of the hospital stay and blood loss was significantly longer with microdiscectomy. The conclusion from the existing outcome endoscopic discectomy, it could be seen as sufficient and safe supplementation, an alternative to open discectomy. And in 2017, this randomized controlled trial study in 140 patients, and the conclusion was the shorter hospital stay and type of anesthesia use are elements to choose the endoscopic discectomy. And in 2020, this study with 27 study, 11 randomized controlled trials, 7 non-randomized prospective, 9 retrospective studies in 4,000 patients. The conclusion was the endoscopic discectomy is superior in outcome measures like Odd-Westry scale, duration of the surgery, in overall complications, in length of hospital stay, and not inferiority in the other measures analyzed. And the conclusion is the endoscopic discectomy has the potential to take over the place of microdiscectomy as a gold standard of care in the management of lumbar disc disease. And this is from the last year. This is the same conclusion. And in relation with the cost effectiveness of full endoscopic versus open discectomy, and the conclusions say that the endoscopic is more cost effective from the societal perspective compared with open microdiscectomy for patients with sciatica. And this another study in the same way that the comparison with the economic point of view. And in conclusion, this endoscopic in lumbar disc herniation is a procedure under local anesthesia, is an ambulatory surgery, has less iatrogenic damage in postoperatory pain, no major complication, satisfactory results, early recovery to work, reduced cost, and I think has a great future. Thank you very much.
Thank you, Enrique. Very nice presentation. We have one question from the chat regarding which approach is more preferable for foraminal lesion, posterolateral or extraforaminal? What's your opinion?
Which one?
The question is for foraminal lesion, which approach is preferable, posterolateral or extraforaminal? Is the question from the chat.
For intraforaminal, posterolateral is the election.
Mm-hmm. And my question also regarding the biportal, biportal endoscopic disc herniation, disc removing. What do you think about biportal technique? I mean, it's something very well developing now, and it's very close to surgery for joints, etc. But what's your personal viewing of this?
Yes, I use in few cases, but I don't see now the necessity to do in biportal when you have the possibility to resolve only with uniportal approach.
Yeah, the same. Other questions?
Abujar, do you want to comment anything about this panel? We are about to finish it. You must unmute. Yeah, okay.
Okay. No, I don't have any comment. I think we have the 15 minutes for the next lectures.
Yeah. I thank all the speakers and moderators and participants for this first WFNS education course on acute low back pain and lumbar disc herniations. I wish you enjoyed the meeting, and we will meet again in 20 minutes or 15 minutes, sorry, for the approaches to trigeminal schwannoma surgery. Okay. Salman? Do you
Yeah, I
want
think
to say something?
brilliant. No, I think it's a brilliant talk. I think Enrique really did justice to endoscopic discectomy. Really enjoyed that talk. I think all the talks were brilliant. And I'm sorry to owner that I gave half his talk. I didn't realize that he was giving the same talk. But I think I just took some of his burden. But I think what you have started is brilliant to do both spine and cranium at the same time. These sessions are going to be great. I think young neurosurgeons can really benefit from it, and these tips from experts would be great. Atul, your thoughts?
You are mute, Atul.
Yeah, Enrique, that was a very fantastic lecture, and your surgical techniques that you showed were very masterly, like, I have seen in the past. Endoscope is an emerging tool. Maybe it is not emerging anymore, it is an emerged tool, and people like you have promoted it to a great extent. I think the way you showed, the way you demonstrated, it is, as you rightly mentioned in your concluding slide, that it might just be the future of this surgery. Enrique.
Thank you.
Thank you. Yeah, we are making a break now and then meeting again in 15 minutes.
Okay.